Welcome to our 6th session, and this is about respiratory care. So we want to look at part 1 of respiratory care, and the session discusses some clinical nursing procedures that have to do with the respiratory system. We will be looking at coughing and diaphragmatic breathing. Oxygen therapy, you are being referred to session 6 of Nurs 337. Remember, it was demonstrated and taught. So watch the videos on oxygen therapy, session 6 of Nurs 337. We'll also look at postural drainage. So our first topic is coughing and diaphragmatic breathing. A cough is a common reflex action that is an immediate response to a stimuli that clears the throat of mucus or foreign irritants. Coughing is either voluntary or involuntary, and frequent coughing usually indicates the presence of a disease. Now let's look at types of cough or coughing. A cough can be classified according to its duration, the character, timing, and quality. A cough that lasts for less than 3 weeks is an acute cough, and a cough that lasts between 3 to 8 weeks, improving by the end of that period, is a subacute cough. A persistent cough that lasts for more than 8 weeks is a chronic cough. We also have productive cough, in which there is excessive production of mucus and phlegm. Unproductive cough produces no mucus or phlegm, is dry. And based on the patient's perception, these two types can be further differentiated into mucus and then chesty coughs. I mean the productive and the unproductive coughs. Let's now have a look at general causes of cough. It may be infectious, it may occur as a result of infections, reactive airway diseases, gastroesophageal reflux, air pollution, and then foreign body. Acute cough may be caused by common cold, influenza, inhaling an irritant, pneumonia, and then diseases like whooping cough. Chronic cough, on the other hand, may be caused by allergies, asthma, bronchitis. Other causes include acute sinusitis, choking, lung cancer, and then heart failure. Now we want to look at coughing exercises, and that is the main reason why we had a general overview of coughs. Coughing exercises help lower the risk of lung complications after surgery, and it also helps to bring mucus from deep within a patient's lung. So normally patients is taught these coughing exercises before surgery and then after surgery as well. We want to prevent post-operative complications. Now, how to perform coughing exercises. The patient is placed in a comfortable position, lying on the back with the knees bent, lying on the side that is in the lateral position, or taking a sitting up position. He or she is instructed to place the hands on the abdomen and then take a deep breath, hold for 3 seconds, and then half out 3 times. So to demonstrate, patient presses or places the hand on this abdomen, takes a deep breath, hold for seconds, and then halves up as a way of teaching patients coughing exercises. So we want to look at diaphragmatic breathing as well. And diaphragmatic breathing is an important breathing exercise which is essential with chronic lung disease. It helps increase the effectiveness of breathing, helps reduce panic and fear when dyspnea occurs. It also helps prevent patients from using less effective accessory muscles when they are short of breath, and it also helps in improving upon oxygen supply. In the picture is a demonstration of how to position patients and then encourage patients to do diaphragmatic breathing. Now let's look at the procedure. With practice of this procedure, the patient should be able to use diaphragmatic breathing without thinking about it. The patient is taught to do the following. Place one hand on the abdomen and the other on the chest, as we saw in the picture. Then concentrate on pushing out the abdomen during inspirations and relaxing the abdomen on expiration. The chest should also move very little. So we teach patients how to use the diaphragm in breathing instead of the chest, which is the normal way. Patient is asked to lie on the back, that is supine, with the legs flexed up, and then pillows placed under the knee with feet firmly on the bed or floor. Patient is then instructed to breathe in deeply through the mouth, and the abdomen should rise slowly and steadily. The chest also moves slightly. He or she then breathes out through the mouth, and the procedure can also be done whilst the patient is in the sitting up position. We may also have another one, incentive spirometry, and with this one, patient is asked to breathe through a spirometer, as we can see in the picture. Incentive spirometry, also referred to as sustained maximal inspiration, is accomplished by using a device. This device is known as the spirometer, and this provides feedback when the patient inhales at a predetermined flow or volume and sustains the inflation for at least 5 seconds. And simply put, is a technique which is used to encourage a patient to take a maximal inspiration using a device to measure the flow or volume. So the spirometry is used in enhancing this technique and measuring the flow or volume of inspiration as well. It's done in patients with atelectasis, patients with the presence or conditions predisposing atelectasis, such as upper abdominal surgery, thoracic surgery, surgery in patients with COPDs, and then we have prolonged bed rest, then the presence of a restrictive lung defect associated with dysfunctional diaphragm. So the primary indication of incentive spirometry is to treat atelectasis. However, it is contraindicated in patients who cannot be instructed or supervised to assure appropriate use of the device, or patients in whom cooperation is absent, or those who are unable to understand or demonstrate proper use of the device. It's also contraindicated in very young patients, especially those with developmental delays. Patients who are confused and delirious, those who are heavily sedated or comatose, and those who are unable to breathe effectively due to pain and diaphragmatic dysfunction. So before the procedure, the nurse has a role to play. The nurse should introduce him or herself to patient, reassure patient to allay anxiety, assess if it will be appropriate for patient to do the therapy, describe the proper technique to the patient, and then the importance of adequate therapy, the technique, perform pre-treatment assessment of breathing pattern, frequency, and then lung sounds. Patient is also put in the appropriate position, that is the upright position, or semi-fowlers, without causing any level of pain. If the patient cannot move, then the incentive spirometry can still be performed if he or she is coached carefully. Then the level of pain is also assessed, and then we administer pain medications as prescribed. Then during the procedure, patient is instructed to sit or position in the upright position, hold the incentive spirometer upright, and then he or she is instructed to exhale, letting all the breath out, and then asked to close the lips around the mouthpiece of the spirometer, and then instructed to inhale slowly, breathing in until unable to do so anymore. In the picture, we have the spirometry and then a patient undergoing the incentive spirometry. So as the patient takes a deep breath, the piston in the clear chamber of the incentive spirometer will rise. And if patient is breathing too fast, there's an indicator which will also show. Patient is asked to hold the breath for at least 3 to 5 seconds. And then you also set the goal indicator tab at the level that the patient reached. And take out the mouthpiece and breathe out slowly. He or she is asked to relax, breathe out normally for a few seconds till the piston returns to the bottom of the chamber. This procedure is repeated 10 times every 1 to 2 hours. And then after the deep breathing exercise, it's important to take a deep breath, for patients to take a deep breath, cough to clear the mucus for the lungs. If patient has had a surgery, he or she is asked to support or hold the pillow or a pillow or folded blanket firmly against the incision site. Then after the procedure, patient is monitored intermittently. We observe we document number of attempts per session, and then we also look at inspiratory volume achieved, patient efforts and compliance, and then outcome of the procedure. So we now come to our last topic under respiratory care, and that is postural drainage. Postural drainage is defined as the positioning of a patient to allow drainage of mucus in all the lobes of the lungs and the airway, and it's usually done with the clapping of the hands on various parts of the body to remove mucus from the lungs. Patient is usually placed in various positions, and each position contributes to drainage of the particular lobe of the lung. So we say that is a gravitational clearance of mucus from the respiratory tract, in which patient is placed in different positions. The sitting up position may be used. We may also use the lateral. Patients may be asked to sit on the bed straddled on the hard table. Patients can lie in the Trendelenburg position with the head hanging. Patients can even lie in the genupectoral, kneeling on the bed. All the various types of positions may be used, and this helps in bringing or dislodging mucus from the patient's respiratory tract. So mostly before suctioning is even done, postural drainage is done. Of late, it's not a common procedure carried out on the ward. It's done in patients with bronchiectasis, lung abscess, those with atelectasis, cystic fibrosis, expectorated sputum production, which is greater than 25 mL to 30 mL per day, and then mucus plug. It's contraindicated in patients with emphysema, spinal or neck injury, because patient will be turned in so many positions. Those with pulmonary embolism, ribs fractures, pleural effusion, active hemorrhage, and then recent spinal injury. So for our requirements, we need a bed that can be adjusted as an adjustable bed, pillows for supporting patients, light towel for covering the area of the chest during percussion, tissue papers, basin for collecting expectorated sputum, and then gloves for protection. We may also need oxygen delivery devices. After the postural drainage, patient may be given oxygen, and then we may need stethoscope for auscultation, mechanical percussor or vibrator, specimen container in case we have to take a specimen of sputum, suctioning equipment, and then face mask. So patients The nursing responsibility include reassurance and then explanation of the procedure to patients. Patients may also be taught coughing exercises. So patient is encouraged to cough, and then he or she is put in the various positions to aid in the bringing out of the sputum. Then the affected lung or lobe, access to affected lung or lobe, cardiac status, structural deformities of the chest wall and spine are also assessed. Then the chest is auscultated before and after the procedure to help identify the areas that need drainage and the effectiveness of the treatment. The chest is auscultated before and after the procedure, and we also ensure that the procedure is done 2 to 4 times daily before meals, because we want to prevent nausea, vomiting and aspiration. And the recommended sequence is positions that drain the lower lobe, then the upper lobe. So the type of position adopted will depend on the parts or side or lobe of the lung being drained. Then during the procedure, patient is helped to assume comfortable positions in bed. He or she is provided with emesis or vomit bowl, sputum mag and tissue papers, and instructed to remain in each position for at least 10 to 15 minutes and to breathe in slowly through the nose and out slowly through pursed lips to help keep the airway open in each position. It's also explained to patient how to cough. That is, patient is taught coughing exercises. Then he or she is suctioned if the sputum cannot be coughed out and is causing irritation and blockage. And then percussion of the chest is done. We listen to the chest for bronchial secretions and the mucus plug. Then after the procedure, patient is assisted to assume a comfortable position to brush the teeth or use a mouthwash to refresh the mouth. And then we also note or document the color, amount of the sputum, the character of the expelled sputum, and then the patient's skin color and pulse for cyanosis. And then oxygen may also be administered if necessary. However, just like any other procedure, it may have a few complications associated with it. It can result in increased intracranial pressure, hypodynamic instability, uncontrolled hypertension, hemoptysis, hypoxia, bronchospasms, aspiration, pulmonary hemorrhage, and dysrhythmias. So in conclusion, respiratory care is very crucial in the recovery of clients, especially in emergency situations, and therefore the nurse is expected to carry out these procedures in time or supervise the patient to carry out these procedures as the case may be, to avoid the loss of lives. So as your reading list again, refer to Smelter, Bear, Hinkle and Cheevers, Brunner and Sadat's Textbook of Medical Surgical Nursing, 12th edition.